Over the last couple of years, many practitioners have begun to see dry eye disease as a chronic and progressive disease that, if not caught and treated appropriately, can become very problematic for our patients. Since the disease is chronic and progressive, patients continue along a continuum of dryness until they become symptomatic, and if the process is not slowed in some way, the damage from the disease may become irreversible. Historically, we focused on symptoms and helped patients feel better, but we now realize that due to the variability in corneal nerves and how our patients feel, we cannot trust that their symptom improvement will reflect their objective signs. Likewise, we used to look at improving what we now call the effects of dry eye. For us, these include staining, injection, tear breakup time, and inflammation. However, we realize that these are just effects of the real cause of dry eye. That brings us to the importance of finding the root cause of the disease. Logically speaking, we either have a lack of tears or a lack of quality tears causing eyes to be dry. Lemp taught us that 86% of patients with dry eye have MGD as the cause, with 50% being MGD alone, 36% being a combo, and 14% being aqueous deficiency alone. As such, for the two of us, we try to break patients into two groups, those that have MGD and those that don't. We utilize the MGE to present 1.2 grams per millimeter squared upon the eyelid to duplicate the pressure that the eyelid exerts upon itself. If we see oil flow, we know that the patient is releasing oil freely when they blink naturally. If we do not see oil flow, we know that the patient has MGD and needs to be treated with the ultimate endpoint of getting oil to flow more freely. From our literature review and clinically, we have found LipiFlow to be the most helpful treatment for these patients. If the patient has dry eye and has free flow of meibum from their glands, we know that MGD is not their problem and they have either a mucin or aqueous deficiency. By utilizing the objective measurements that we collected when looking at the effects of dry eye, we're more accurate at differentiating which type of dry eye the patient has, and then we tailor our treatments around that cause. Ultimately, we want the cause to be cured or managed as best as it can be. Then we look at the effects showing long-term improvement, all the while looking to bring symptomatic relief to the patient. By turning the problem upside down and looking at the root of the issue, we can more accurately treat and slow the progression of this chronic and frustrating condition and ultimately enrich our patients' lives.